Thank you for joining Stoughton Health for tonight's presentation on hormone therapy. My name is Kelly Perna, and I'll be your host for the session. To ensure a smooth experience, I'll be muting everyone during the presentation. Afterwards, please ask your questions either using the chat or unmute and ask aloud. I'm pleased to introduce Dr. DeGreve. She is a medical doctor driven by a passion for helping patients achieve balance and vitality, designing approaches that address the unique challenges of modern life. Her practice integrates evidence-based medicine with personalized care plans to support optimal health and well-being. Dr. DeGreve is a Menopause Society certified practitioner. And with that, I will pass it over.
All right. Thank you so much for being here today. And thank you for taking the time. I know everyone's really busy. So I hope you're somewhere comfortable. Grab your hot tea and let's dig in. I am Dr. Ann DeGreve. I'm board certified in family medicine. I am a menopause certified provider. I'm a diplomat of the American College of Lifestyle Medicine and the medical director and physician at Empower Wellness. And hopefully soon, also obesity medicine certified. I just took the board exam. So today I would like to talk to you about something that is very near and dear to my heart. I had hormone challenges when I was younger because of morbid obesity. I was a very heavy person, and I also had PCOS. And then I lost a lot of weight, about 100 pounds, and my hormones were completely out of sync from all of that. The first time I lost 100 pounds, yes, I did it twice. I didn't do it a smart way. I did it too fast and with too extreme of changes and really did a number on my hormones. Second time around, after I gained the weight back, I lost it again. But then had a lot of work to do to rebuild myself. Additionally, when I hit about age 42, I'm 45 now, I started having brain fog. I started having trouble remembering my patients, what I had to do that day, medications that I could easily call up day after day. I started having trouble with. I had terrible joint pain. I was having all these random symptoms, palpitations, and I thought, what is happening to me? I'm losing it. What am I going to do? How am I going to provide for my family if I have to work for another 20 years and I can't even think? And then my periods started getting closer together, and I thought, oh my goodness, I'm in perimenopause. So it took me a long time to find a physician that was supportive of my cause. But finally, I found somebody to prescribe me medication, and they tried birth control. We'll talk about why that's not the same thing in a little bit. Anyway, long story short, after I finally got everything squared away and felt like $1,000,000 and like my old self again, I thought I have to share this with the world. So thank you for being here today. Let's talk about it. Menopause affects the entire body because we have estrogen receptors everywhere. So that's why perimenopause is so strange in its effects, because it can affect our skin, our hair, our brain, our joints, our bones, our weight. You have been eating and exercising the same way forever. Now you're gaining weight around your midsection. It is just a crazy time for everyone. So this slide kind of shows you just some of the things that menopause can do to you. And no, you're not crazy. It's menopause. This is another one. I have patients come to me all the time. Why are my eyes dry? Why is my skin dry? Why am I suddenly anxious? I've never been anxious. Why am I depressed? My life is fine. All of that can be because of our huge fluctuations in estrogen over the perimenopause transition. So when we are pregnant, our estrogen levels are about 3,000. So we have levels capable of 3,000, and then after menopause, 0. You can imagine what this does to the body. And in perimenopause, it's all over the place. You might have no estrogen one day and then a level 800 the next day, which also makes it challenging to get lab results. And we can talk about that too. So some things that people think of when they think of hormone replacement therapy, they're kind of thinking about birth control. And again, we'll go through why that is different. So hormone therapy for menopause and perimenopause does not increase your risk of blood clots or strokes. So some people think, oh, I'm going to get a blood clot. It's not true. Breast cancer also. The progesterone that we use for hormone therapy is not a synthetic or androgenic progesterone like some birth control pills are. So it is not contributing to our breast cancer risk. Also, hormone therapy can help strengthen our bones. It can help prevent colon cancer. It helps keep insulin resistance at bay, so we're less likely to get diabetes. Helps with heart disease by keeping our blood vessels healthy and our brain healthy, which helps prevent Alzheimer's disease. So the challenge with perimenopause is it can start as early as 35, or if you have surgery and you had your ovaries removed, that's when your menopause starts. So that transition between about 35-ish to whenever your last period is, that is a time of just utter chaos in your body. And that's why I'm here today to tell you there is hope. It gets better. Menopause is considered when you have had your last menstrual period and then 12 consecutive months elapse with no period. So you are not menopausal until you've gone 1 full year without a cycle. And then post-menopause, sometimes these women get forgotten completely when that is a time where vaginal estrogen can really be helpful in preventing urinary tract infections and discomfort in the vulvovaginal area. So I had alluded to hormone therapy not being the same thing as birth control. They use different estrogens, for one. The delivery method can be different, and the progestins are different. So the estrogen in birth control is much higher, and that is why it can cause problems when you're in perimenopause and menopause. It's a little bit too high. So it can increase our risks of blood clots and strokes and other issues as well. It's not cardioprotective. It's not strengthening our bones. It's a totally different compound. Same thing with the progestins. And sometimes we can use that to our benefit. And I'll talk about that when we talk about endometriosis. So the estrogen and progesterone that are used in hormone replacement therapy help with keeping your blood vessels healthy, help keep your bones strong, help keep your brain healthy, and also affect your mood in a positive way. Helps decrease depression, decrease anxiety, and there's no blood clot or breast cancer risk. And we'll talk about why. And then the estrogen and progesterone in contraception is safe in young women because they really don't have that risk of blood clots and strokes unless they have a clotting disorder or other things that predispose them to that risk. They're just not at the same risk as we are as we age. It can increase your cholesterol a little bit too. Again, if you're a young woman and your cholesterol is well within a healthy range, nothing to worry about. But as we age, those little changes can make a big difference. I also put in here something about insulin resistance. You do the contraception hormone therapy can increase your insulin resistance a little bit. Again, in a young, healthy woman, it doesn't really matter as much. And the slight increase in inflammatory markers in a young woman, again, generally don't cause as much of a problem. However, if you have a young woman in your life who is struggling with any of these things and they're on birth control, you might have might want them to bring it up with their doctor because there are other combinations and options that are better. So I put this in here, even with a link to an article about it. It's a little bit counterintuitive. So it's not estrogen specifically that increases a risk in breast cancer, but the progesterone that increases the estrogen signaling, and it's dependent upon the type of progesterone. So micronized progesterone used in hormone replacement therapy does not increase breast cancer risk. So unless you personally have an estrogen-based breast cancer currently, you are probably a candidate for hormone therapy. Even if your mom had breast cancer and your aunt had breast cancer, if you personally do not, you are probably a good candidate for hormone therapy. But it is sometimes hard to find a doctor who knows that because it's relatively new information. So hormone therapy replaces what we naturally produce. It is estradiol and micronized progesterone, and roughly beginning age 40 is when we start therapy. You can start all the way up until menopause, but the projection or the protection, like the cardio protection, the brain benefits, the bone benefits, are better if started earlier. And then also, as I had kind of said in the previous slides, all of these things like the brain fog, the discomfort with sex, vaginal dryness, urinary tract infections, night sweats, hot flashes can all get better. Testosterone, I liken to the sprinkles on top of the ice cream. Testosterone therapy can just be that last little boost to really feel like yourself again. It can help with lean muscle mass, help kind of reduce that mid belly fat, and also help just make you feel a little bit more vital. So I do like to use testosterone in my practice as well. So the types of hormone replacement are estrogen. We generally use the patch because it bypasses metabolism through the liver. And that's why it doesn't cause an increase in blood clots, because it's not the same metabolism as the pill. So there is an estrogen pill that you can use in hormone therapy, but I generally would not. The subdermal pellets, that's where you have a pellet of compounded estrogen injected into you subcutaneously, like right under the tissue. I don't use them because they're not FDA approved. They're compounded at the site where you're getting them. And once they're implanted, they can't be gotten out. They're not visible on an x-ray. So if you were to have a stroke with a pellet in, because let's say accidentally there was too high of a dose or you had a bad reaction to it, you can't get it out. You're stuck with it. So I took an oath, do no harm. I don't do the pellets. Vaginal ring is another option. There is one specifically for hormone therapy. There is also one for birth control. Progesterone is generally oral because it's a large molecule. So there is a patch, but it's not, I mean, it's reasonably well absorbed, but not as well as the oral route. And the IUD with progesterone that's sometimes used in hormone therapy is a synthetic progesterone. But there's a use for that, and we'll go over that later. Then the testosterone we use is generally a gel or a cream. There are other options. The patch you have to change very frequently, so that can be annoying and irritating to the skin. The implant is the same as the pellets of estrogen, so I don't like to use those. And the injection, I'm not a big fan of either, because right after the injection, the level goes very high and then slowly comes down. So the risks of testosterone, where it can thicken your blood and cause blood clots and strokes, are a little higher with the injection, so I tend not to use that. So there are no formulations for women yet. It's on the table, so hopefully that'll get done soon. So right now we would have them sent to a pharmacy that can take the men's dose and put it in either a pump or a cream so that it is dosed appropriately for you. You can use the men's tube and just do 1/10 of it, but sometimes that's a little bit challenging because you're like, how much is 1/10 of this tube? So there are options. And then I'm going to dip my toe in the water a little bit for some non-hormonal options. So SERMs are one option. One is Duovy. Duovy does have estrogen in it, but it does not have progesterone. So this is for people who don't tolerate progesterone. It's specifically for hot flashes and bone health. I will say I don't tend to prescribe this just for personal reasons, but I will if someone asks me to. Why? Because it uses conjugated equine estrogen, which quite like the name says, comes from mare's urine, which is, if you want to look it up, it's not a practice that's very pretty. So I don't tend to use that a whole lot. Then the other one is ospenephine. That one's specifically for painful sex and to help with bone density. It does not require progesterone with it to protect the uterine lining. It increases your body's response to estrogen. It binds to receptors and acts like estrogen, but it's not estrogen. So this one is an option for people who have any kind of estrogen-based cancer or really any indication whatsoever. So that's a good option if you're having any of those issues. And the last one, Veoza, is specifically for hot flashes. It works in the thermoregulatory center of the brain. It is not hormonal. So that one is for if you're having terrible hot flashes, you can't take estrogen for a variety of reasons. That's a good option. So this is not exactly true anymore, and I'm excited about that. Absolute contraindications are based on old data using oral medications and much higher doses. So estrogen-based cancer is still an absolute contraindication. If you have a estrogen-based breast cancer that you are currently battling, you are not a good candidate for hormone therapy. However, if you're cured and your oncologist says you are able to receive this, you can have hormone therapy after breast cancer. If you have a high risk of blood clots, again, it's only for oral dosing. The patch does not increase your risk. A history of heart attack or stroke within the last 3 to 6 months. Guidelines are evolving on this because we're again finding that the patch does not increase your risk. Migraine with aura, also only oral dosing. So relative risk, again, I sound like a broken record, oral dosing. So if you have uncontrolled high blood pressure, uncontrolled triglycerides, oral estrogen can make it worse, not the patch. So endometriosis. I added this to my talk because I've had a lot of people come into my office and say, well, I was told I can't have hormone therapy. I have endometriosis. That's not true. So if you have endometriosis, we have to go over your history and talk about when did it flare? Did it flare with periods, between periods? If you've ever been pregnant, how are your symptoms? And then we can kind of gauge how did your body respond to those different estrogen levels in your life? And what's the best course of action for you? Anyone who's had endometriosis can have progesterone. Progesterone will help with sleep. It will help with your mood. So that is at least something. If you're looking for the estrogen benefits for your heart and your brain and your bones, you can use estrogen. You just have to make sure the progesterone is high enough to keep those endometriosis lesions quiet. The thing that can be a little troubling to some people is it is trial and error. So we may start you on what we think is the best regimen based on your history, and you may find your symptoms return. Then all we do is have to stop the estrogen or change the dose. But endometriosis is not a contraindication to hormone therapy. When you start hormone therapy, you can have some irregular bleeding in the first 3 to 6 months. That's normal because your body's estrogen receptors are now finally seeing, the estrogen is back. And that can make the lining of your uterus change those first 3 to 6 months. So if that continues after that, or you're having irregular bleeding, or it's really different from what your history has been, then you may want to do more workup. We might want to look at labs. We might want to look at imaging and just make sure there's no fibroid in there or other reason why you're having bleeding. Speaking of labs with hormone therapy, getting labs is a little bit like a pot of soup. If you dip the ladle in, you might get a bunch of potatoes. And the next time you dip the ladle in, and you get a bunch of carrots. It's still the same soup. So labs can be really irregular and misleading. But if we're not sure you're absorbing from the patch well, or you're not getting relief and we've changed the dose, then there might be a good call for running labs. And based on when you do it, if you're still cycling, you can get better results. And then depending on the type of either blood lab or saliva or urine testing, you can determine which is going to be the most accurate for you and what's the best way to go. So I generally don't do labs. We go off symptom control, but there's definitely a place for getting labs if things aren't going as you expect them to go. Then other people will recommend, going back to the slide here, cycling progesterone. So it's like your cycle, and it can make your cycles more regular. So usually you'd use progesterone in the second half of your cycle and then have a period. However, most people don't like that because for those, 12 days, 14 days, you're sleeping better, your mood's better. Why not just use it all the time? Do the progesterone every day. You can do that, and I recommend it. I like it better because I like that constant good sleep. I like that mood improvement, and over time it'll thin the uterus and you may stop having periods or they become very light. So I kind of like the daily, but there are some people who like to cycle it. If your bleeding is a little irregular and it's driving you nuts, there are options to control it. NSAIDs or TXA. Your menopause provider can go over that if you're having trouble. Then you could also use different types of progesterone to control bleeding. You also need to consider, do you need birth control? So if you are in that 40 to 48-ish range and still having some cycles, you may have a viable egg. So unless your partner has birth control on board, or you've had surgical birth control, you need some kind of birth control because you probably don't want a surprise baby at 48. Some people do, but I would find that challenging. So there, you can do estrogen patches plus the progesterone only pill. That's one option for birth control. You could do progesterone patches and an IUD. That's another option if you're wanting hormone therapy and birth control. Again, sometimes that can be a challenging discussion for your regular day-to-day doctor, so that might be a good conversation with a menopause specialist. And then the most important and easiest, yet hardest thing to do, lifestyle factors. So making sure that you are supporting your own body's health by eating healthily, optimizing your sleep, maintaining a healthy weight. And hormone therapy doesn't contribute to weight loss. But what it can do is make you go from feeling like a slug who's depressed on the couch and not sleeping well to finally feeling well enough to take care of your body. So I don't like it when people say that hormone therapy will help you lose weight. It won't. In fact, you can have a little bit of water weight gain in the first few months. We're talking 1 to 3 pounds, not 20. But it can make you feel more vital and more healthy so that you can maintain your weight. And then, of course, physical activity. You got to move your body. This is my contact information if you have questions that we don't get to tonight, or if you want to email me, please feel free.